Okay. Hi, good evening, guys. Welcome back to another session of webinar with Beating Hearts. Today we have Dr. Adrian Yong. Dr. Adrian was previously a professor with University Hospital, trained in London, and currently has his own practice, but he's also practicing in Beacon. One session a week. I think that helps you quite a lot with the very interesting cases, right, in the hospital.
Yes, that's right.
Yes, right. So I think without further ado, we just ask Dr. Adrian to maybe give us the talk. And this session is meant to be interactive. Am I not right, Adrian?
Yes.
Because we are going to do spot diagnosis. And yes, go ahead.
Okay. So I'm going to share my screen now. Just want to confirm that everyone can see my screen.
Yes.
Yes. Okay.
Yes.
All right. Great.
Maybe you put play.
Yeah. Okay. Is this better now? Great. Okay. So good evening, everyone, and thanks for joining us. It's a great pleasure to be invited by Dr. Patty to share my area of interest and passion with you. So this evening, we've chosen the topic of the spots because for most people, dermatology is a very short stint within medical school, and everything is macular-papular. So this evening, in the next half an hour, I hope I can impart some basic analytical skills with regards to dermatology. So in the next 30 minutes or so, first of all, we'll do an overall overview of approach to dermatology, how we go through what we see, and we will hopefully come across 9 common conditions or certain conditions that may look common, but they're not actually that common, and certain other diagnoses that if you have missed, you would certainly be mismanaging the patients until the patient ends up with another doctor who sees it very clearly. So I think the first picture that I'm sure most of us feel whenever we are, especially for those who have done membership exams, and it's a dermatology question or station, and they're looking, oh dear, what is this? And they're looking at the stripes. They think, okay, fine, stripes, it must be a tiger. Spots, it must be a leopard. So as simple as that. But what if you have spots on a zebra body? Is it a Libra or is it a Zephyrd? Okay, so obviously those are made up animals, which is a crossover between the two. But the way to do dermatology is not to just spot the spots, which is a bit of the, a misnomer in a way. Because the way we have to do dermatology is to be as interactive as possible with the patients. You have to know what they do, what they've done, what they have put on their skin, and how it has evolved over time, together with what you see on that day. And hence, picture quizzes over WhatsApp are never a good idea, and try not to do a consultation just with a photo. All right, so the first thing we would like to cover is stripes and spots. So would anyone like to just volunteer and perhaps go through any of the slides here? You can choose whoever who wants to go first. You can choose number 1 to number 8.
Okay, guys. Okay. Yeah, just give them some time.
Okay.
And for all you know, they can do 1 to 8, all of them.
Yes.
I can. Okay, I can't. I used to be very good. I wanted to be a dermatologist actually, but I didn't. I rather have my adrenaline drive than yeah. Let's see. So Monisha said number 6 is onychomycosis.
Okay.
Okay.
All right.
Who else? Anyone else? Okay. Gobinda said number 8 is melanoma.
Okay. All right.
Okay. Anyone else? This is good. Okay, let me try. I think oh my God, they all look quite the same. Okay, Sakina thinks that number 7 is melanokia.
Yeah, melanonikia. Okay.
Okay, never mind. Come on, guys. Okay. Ying Zite says number 3 is subungual melanoma.
Okay.
And Dr. Kaur thinks number 2 is subungual hematoma. Actually, I have this subungual hematoma, and my toenails yesterday, the whole thing came up.
Yeah.
Okay. Dr. Nick Haslin thinks that number 2 and number 6 are the same diagnosis, which is onychomycosis.
All right.
Okay.
Okay.
Any more? No more.
Any more?
Okay.
So perhaps the approach, maybe you just guide with approach.
Okay.
So actually, this is a little bit cheeky. Actually, all of them are melanoma. All of them.
All of them are melanoma.
Yes, all of them are melanoma. And what we are trying to get across here is, number one, you look at the nail first, and you look at the pigmentation, whether the pigmentation is in the nail or is it under the nail. Okay. So this punch biopsy, you can see 2 holes here. This punch biopsy can help us look for whether the pigment is in the nail or is it under the nail. So Betty, what you mentioned earlier about subungual hemorrhage, if you were to punch a hole in a nail, you will see that the blood crust is underneath, which means that you can still see the discoloration underneath, whereas this is just a hole, which would suggest that the pigment is within the nail itself. Okay.
I see.
Now, a pigment within the nail, if it's linear and the history is very, very long, for example, 5 to 10 years unchanged, it's very unlikely to be anything sinister, which is the one over here, which I've put a photo here. Because this is one of my patients who came to me very worried, thinking that this is subungual melanoma, and the history is that of 10 over years. But when I dig deeper, they were actually more concerned about the appearance and said, you know, if it's not cancer, then, but it keeps staring at me every night and I keep having nightmares that it might be melanoma. So what I did for this patient was actually to use a pigment laser to break it down. And immediately the whole pigment just disappears because it shatters it up. But I tell them that we can only do that if we are very sure that it is not subungual melanoma first. So how do we do that? Few signs. So if you remember Hutchinson sign, which is the pigmentation in the periungual space around here. So the proximal nail fold is pigmented here. Here in the distal nail, and the distal nail on the skin here, and here as well. So all these where the pigmentation has actually gone to the skin or the nail bed is actually pretty advanced melanoma. It's actually spreading across onto the skin side as well. So don't be surprised that when we do a full nail avulsion, which we would do under local anesthetic, we then see all the pigment here that we have to take a wide excision. And if the melanoma Breslow thickness is more than 2 millimeters in depth, normally you have to go 2 or 3 centimeters around. Okay. If it goes any deeper than that, we need some scans to see whether there is any regional lymph nodes in the areas such as the armpits or the groin for that matter, if it's the feet. And then you may have to refer to orthopedics to get the toe amputated if it is invasive melanoma. So it is as serious as that. And one of the commonest misdiagnoses, as we've already come across this evening, is that of nail onychomycosis. Okay, so just be very careful. With nail onychomycosis, the history should be fairly short. Okay, however, you shouldn't get any sort of skin changes around the edge with pigmentation. So with any sort of doubt that you may have, you can get a nail clipping off and send it for mycology. And if you don't get any positive mycology, then it's time to refer on for a more accurate diagnosis and biopsy, because this is something that you shouldn't miss.
Okay, can I ask you, this melanoma, is it affecting the skin under the bed of the nail, or is also affecting the nail?
Okay, so as you can see here, it actually starts from the proximal nail matrix. That is where the root of the nail is. Okay, so if it was a longitudinal melanonychia, which means it's a mole but equivalent on the nail surface, it will start here and just be a streak, and it does nothing else like this. Okay.
Yeah.
If it starts to invade to the sides here, it means that it's gone through the nail and it's gone onto the nail bed. So there's local spreading. Okay, local spreading. So by the time it goes into the skin here, very often you need pretty advanced wide excision. So the first sign when you start seeing these pigmented nails, that's the first time to try and capture it. Okay. So if you have a punch biopsy, it's quite easy because you can just do a little puncture and you have a look. If there's no pigmentation underneath, then it's unlikely to be subungual hemorrhage, which means at this stage, you better get this referred on to get this biopsy to check whether it's melanoma or not.
Okay, go on, because I'm going to check my nails.
Okay.
Because really, honestly, yeah, I have this color toenails, but it was after I went hiking for about maybe 16 km.
16 km, okay. So you can see here,
okay,
how do we work out what sort of pigmentation it is? Okay, so does it involve one or more digits? Is it several? So of course, as we learn in medical school, if it's unilateral, could be infectious, could be malignancy, right? If it's bilateral, then you're thinking more of systemic, racial, pregnancy-related, maybe certain systemic drugs as well, okay, which causes pigmentation like tetracyclines. Then, of course, trauma, for example, is the nail associated with sort of something dropping on the proximal nail fold, which then causes the whole nail to become deformed, which is the commonest cause with the history. So if someone walks through the clinic, shows you a pigment on the nail, first question, how long has it been? Number 2, has it changed? Number 3, do you remember injuring it? Number 4, do you play sports or anything that may explain it?
okay.
And then the options there are dermoscopy with a magnifier and with polarized light to see whether it is on the nail or does it any other areas on the skin or the nail bed or the nail matrix that's involved. If you see any signs of pigmentation on the skin or the nail matrix, then you should either do the biopsy yourself or refer the biopsy on and keep a close eye on the patient. Okay, don't just say observe and then let them drag on, because
that's right.
In my time in UM, there was a Malay gentleman who came to us and was reassured twice by his GP, but he had exactly what you've seen there. And by the time we excised it, he needed an amputation. It was about 2.5 years down the road. Yeah.
So it's quite slow growing, would you not say, if it's 2.5 years?
Yes, quite slow growing. But he's fortunate that it didn't metastasize, because if it did metastasize, then of course he would be needing other chemo drugs, yeah, and even some of the newer monoclonal antibodies to try and treat his metastatic melanoma.
Sorry, Adrian, can I just ask you a few questions? Because for myself too, and also for a lot of the audience who are not medical, what is melanonychia?
Okay, nychia is the nail. So if you've heard of paronychia, which is inflammation of the nail sides of the nail. So melano means pigment.
I see.
Okay. So if it's longitudinal, means it's just long, one strip. Melanonychia, which means it's a strip of dark nail. Okay, and when we use the term longitudinal melanonychia, we mainly mean it's benign. It's not melanoma. Okay.
Thanks.
Okay. So shall I move on?
Question? Yeah, I think so.
Yeah, okay. So now, this would be an interesting one. So let's do the quiz again.
Okay.
And there are actually 4 photos, but 2 of these on the top
are the same person?
Are the same condition, and 2 of these at the bottom are the same condition. So that will give you a hint as to how I put them side to side to illustrate the difference, but it's a bit tricky. So perhaps the quiz should go like that. What questions would you like to ask the patient if you were to see either one? So you can choose either the top row or the bottom row, and then you can tell.
So what in the history would you try to get to come to this diagnosis? First question. Okay, anyone? What would be in the history? Okay, Tan says, any stress recently? Monisha said onset and duration and any history of scratching. Imala said, is it itchy? Serena said, any contact with any substances? And then Farah says, have you have any history of allergy? Okay, so this Kalai. Okay, and Kalai actually said that all 6 pictures were the same diagnosis, but she got the diagnosis wrong. Okay.
Oh dear.
Yeah. Remember the 6 pictures of the
Yes.
nails? Yes.
Okay.
Okay. And then Robin says, feeling after scratching, any insect bite. Okay, Nimala says it looks like typical wheals and flares.
Okay.
Urticaria. Okay.
Good.
Okay.
Good.
Now we come to diagnosis, or do we?
Okay.
Okay.
So let's go
Hustin
through.
hold on. Dr. Nick Hustin says, any similar episodes before this, or is this the first time?
Okay.
And Dr. Lim Chuan Long says dermatographism
Okay. Very
at the
good.
top and urticaria at the bottom. Okay.
Very
Let's
good.
go.
Okay. So these 2 pictures here, these are hives or urticaria.
Okay.
Now that we've established it's urticaria, what is the distinct feature of urticaria that you will have to ask to convince yourself as the doctor that this is definitely urticaria and not systemic lupus, say, or not eczema, for example? What is the precise history that you have to get, that you have to assure yourself that this is urticaria?
There is a precipitating factor. Okay. Duration, Serena said.
Yes.
Okay.
Duration is a hint, correct?
Go on.
Okay.
Okay, Dr. Lim says that the lesion in itself will disappear within 24 hours.
Absolutely. So I think the key question here is very, very important. When you ask most of your patients, does your rash disappear? Is actually not accurate enough, because some patients will be as simple as saying, yes, the rash came out on my arm in the morning, but by afternoon it went to my body. For some people, they will describe it in that way. That is consistent with urticaria. But the mistake that some doctors make would be to ask, does your rash last all day? And they will say, yes, it does, but not in the same areas, you see.
I see.
So you have to be very specific, because urticaria can move from one place to another. So it might be on the face in the morning, body in the afternoon, feet at night. And they will say, yes, the rash is all day. Okay, now, by definition, urticaria is histamine release within the dermis due to mast cells releasing histamine.
Okay.
That's why it causes swelling, itching, sometimes burning sensation. Okay, now, urticaria, you have to be very patient, because you typically need about 15-20 minutes at least to figure out in the background what the precipitating factors might be. Okay? So firstly, has it been there for months and months, or is it just been there for 1 or 2 days? Okay. Now, if it's 1 or 2 days, then you need to look at the groups of, for example, number 1, medications. So the top few medications that can cause mast cell instability or release of histamine includes non-steroidal anti-inflammatory drugs,
Okay.
and cough mixtures like codeine, because morphine also causes mast cell instability.
I see.
Okay. Yeah. So now, so that is the basic thing that we need to understand first. All right. Now, then the urticaria itself can then be divided into acute and chronic. So for acute urticaria, definition is less than 6 weeks. Chronic urticaria, longer than 6 weeks. Okay. Now, if it's chronic urticaria, then the triggers such as food-related becomes a lot less likely, because most people will be able to identify what triggers it and stop doing that to themselves. So when they come to us with chronic urticaria, the yield of an IgE blood test, which is, the whole panel of dust mites, food, seafood, and etc., the yield for a positive result in that case is only 1 or 2%. So it's not the first test that we would jump to, because otherwise the patient will be paying through their nose and not necessarily finding the answer and getting frustrated. Okay. Now, the other way not to approach urticaria is just to say, yes, it's urticaria. Let's stop there and just treat the urticaria, which means you give them oral steroids, oral antihistamines, and say, okay, go off, and then see you. If it doesn't get better, then come back. Because that way, you may not be able to identify what the underlying cause is, right? So without the history, if you're just treating the symptoms, for example, and for example, if they have an underlying infection like sinusitis or a tooth abscess, or for example, even H. pylori infection, can cause chronic urticaria. And if those things are undetected, then the urticaria can go on and on and on. And it's not uncommon for people to then just self-medicate with antihistamines long-term without ever getting a diagnosis.
Okay. You mean even a Helicobacter pylori infection can cause urticaria?
Yes, and it causes chronic urticaria. So it's not like, 1 or 2 week history. Those ones are normally, oh, I've had it for 6 months, 1 year, and it comes on 7 to 10 days in a row and then disappears for a week and then it comes back again, and when they do, very commonly, you would do the IgE RAS test. House dust mite is very common. So that will be taken as, oh yeah, house dust mite is positive. So definitely you're allergic to dust, so just avoid dust and you'll be fine. But without probing further as to whether they actually have this nasal symptoms or not. Because if house dust mite allergy is at play, commonly you would get sneezing, runny nose, itchy eyes first, followed by urticaria that comes on later on. Because the aeroallergen would trigger the responses in the airway before the skin. Okay. Yeah, so it's a lot deeper than what most of us would think. Now, back to the point of demographism, there's also a whole host of what we call physical or inducible urticarias. So the easiest thing that you can do in our patients is to get the back of a pen and just use the pressure and just press down, okay? But we also have a device called Frick test, F-R-I-C-T, which is basically a fancy name for 4 little protruding things at different lengths, and we just streak it along the arm to see at varying pressures. And whilst you talk to them, as soon as you get the history that they might be urticaria, you start doing that on the forearm, and you carry on taking the history. After about 10 or 15 minutes, you'll be able to see if it comes up. And if it comes up, that's positive demographism. Now, when you do that test, you have to make sure that antihistamines are not on board in the last 24 hours, because otherwise you might get a false negative. Okay, what does it mean if they have positive demographism? It just means they're very sensitive to pressure. So if they have a very strong power jet when they're showering, that may cause that to come up. Secondly, if they use a towel and it's very, very rough, that may also trigger a reaction.
Oh, I see. Now everything I relate to myself.
Yes.
Okay, so I do have this friction kind of it comes out. For example, there was when I was very young, there were clay making classes, and it swirls, and then you put. I'm not sure if you watch Ghost. Is it the
Yes.
movie Ghost?
I remember that show. Yes.
Yes.
Patrick's, yeah.
Yes, Patrick Swayze and what's her name? She was so beautiful then. Okay.
Demi Moore, yeah.
Yes, so she was so beautiful in that movie. So yes, when I do that, I get all my hands become really red and swollen because I think it's the friction, right?
Yes, so friction may bring it up. There are also more interesting ones. So I've seen a couple of patients who are wearing jackets into the clinic, and they say, I can't go shopping in Jaya Grocer in the frozen section without a jacket because they'll be itching like mad. And they have something called cold-induced urticaria.
Yes.
Cold-induced, yeah. So those are, if they hold an ice block or it just really swells up and it gets very itchy. Then there's also,
why did I had this when there is a change of, let's say, temperature. For example, I'm either a cold shower or suddenly a very warm shower. But it just went away. I mean,
yes. So yeah, these physical triggers tend to last for a very short time. But if you have a history of those triggers beforehand, and now it's getting more frequent or it's taking less to trigger a reaction, then it's very likely that they're aggravating factors. So aggravating factors include the histamine releases like alcohol, cheese, especially blue cheeses, and seafood.
I
Even
see.
though you may be IgE negative, that means you're not allergic to them, it may still trigger a very strong urticarial reaction because of the potentiating factor where it releases more histamine.
Okay. Dr. Lim asked, how often is chronic urticaria due to underlying thyroid disease?
Not very often, but we see it from time to time. So if someone comes in with chronic urticaria, we should just do a basic blood, which includes full blood count, kidney, liver, thyroid, and then H. pylori probably. Syphilis and HIV, if the history is suggestive of that, may be added on as well.
I see.
If the patient has having hypothyroidism, i.e. low thyroid, it may be related with autoimmune urticaria, where the person produces autoantibodies against their own skin. And that can be tested with a method called the autologous serum skin testing. So what we can do in the clinic is just draw blood, put it in a red universal tube container, centrifuge it, spin it down for about 15 minutes or so, take out the serum section, draw it up, and just inject a wheal, as in a bleb, intradermally into the forearm, and use normal saline as a negative control, just to make sure it's not a physical related trigger like pressure or something else. Then you wait for about 15 minutes and then you see. If the wheal in the patient's own serum flares up, it means that there are autoimmune factors. Now, these patients may go as far as requiring systemic immunosuppressants, such as cyclosporin, or more commonly now, we use things like methotrexate or omalizumab, which is the new monoclonal antibody for very severe chronic urticaria.
Okay, Farah asked, can we get both dermatographism and urticaria together? Are they the same disease as in the pathophysiology behind it?
Yes. So the causation is histamine release. So both of them are due to histamine release, and it is into the dermis, which is why when the swelling and itching disappears, there's no peeling of the skin. Okay, so the key feature here is there's no epidermal change. It is in the dermis. Yeah, that's why you can see the swelling that then disappears after that completely. Right. Okay, so
She asked whether are they both the same?
they are both.
Can we get both together? Yes.
Yes, certainly. You can get both together. Correct. And it's very common that if you have physical urticaria to start with, when you have other forms of urticaria coming up, it confuses the picture a lot. So a lot of people will think, oh, you know, this was a different pattern from now. So one of the confusing parts are some patients get palms and sole itching and swelling at the end of the day, and they think that, oh, you know, my liver is failing or something else. And actually, when you get a history of urticaria in the background, you then realize that they actually have delayed pressure urticaria. So the next question you ask is, do you sometimes get it around where your bra strap is that's very tight, or your bag, which has a very narrow kind of a carrier band, which puts pressure on the area? That can actually trigger the urticaria at the end of the day. So it takes around 6 hours before the hives actually come up. So because in the palms and soles, the swelling are a lot deeper, you don't get this welts coming up. It's just basically the whole thing is swollen up.
Oh, yes.
Yeah.
Like me, okay, I see.
Okay, so let's look at the stripes above, because the stripes are actually a different diagnosis. And I thought we would get past the urticaria part a little bit quicker. But anyway, because we have a lot of other things. So with the top part here, we've actually got this condition which is not well recognized by a lot of people.
Okay.
But once you know about this condition, you'll be able to diagnose it a lot more frequently than you would otherwise. So this is called flagellate dermatosis. So it looks like someone or a jellyfish has like kind of whipped you or flagellated you with a whip. Okay, and this kind of strips stays on for 10 days to 14 days. So if you were the doctor looking at this and saying, oh, does it go away? No. Are you sure it doesn't go away? It's because you haven't seen flagellate dermatosis, because you keep thinking it has to be high. So the history it's not in keeping with demographism. But this is flagellate dermatosis. So
which
where
one
do we
is this again?
flagellate? Yeah,
which picture is this? Both the top?
Yeah, both the top here.
I see.
Okay, so I'm going to go to the next page so that you can see it more visibly. So flagellate dermatosis, you can see that it is the commonest causes that we see here are actually due to shiitake mushroom ingestion, the raw undercooked ones. Okay, and you would think it's urticarial, but actually it's not. It's actually epidermal as well. So you get a bit of swelling, a bit of itching, and then the surface also peels a little bit. The other situation I see sometimes in Beacon is because they're on chemotherapy, and chemotherapy can also induce a flagellate dermatosis. Okay, and of course, all the other causes are things like through flagellation and all that, where there's a true injury to it, okay, where they whip themselves and so on. Okay, and then I think in GP land, you may see this in a post-viral situation, chikungunya fever induced flagellate pigmentation. So those are just interesting differential when you see that, and it's not dermographism. This is flagellate dermatosis. Okay.
Oh, okay. Dr. Koh asked whether chronic urticaria can be cured.
Chronic urticaria can be cured if you find the underlying cause. But if it's chronic spontaneous, it is very, very challenging because it comes and goes as it likes. But the key defining feature of whether it's sinister or not is the responsiveness to oral antihistamines. So according to the European Academy of Allergy and Clinical Immunology guidelines now, we actually updose oral antihistamines up to 4-fold. Okay, so standard dose once a day, not working twice a day, not working 2 tablets twice a day. Now, when we come to selection of antihistamines in this situation, we'll try not to use sedating ones. So for example, Piriton should not be used because it's too short a half-life. And also it causes a lot of drowsiness when you updose. Okay. Cetirizine or Zyrtec, our previous favorite. But when you updose it, it causes a lot of daytime drowsiness and tiredness. Levocetirizine or Glenset, common ones, has a similar problem when you updose it. So the 2 oral antihistamines that I would recommend trying if you were to updose are fexofenadine or bilastine. Loratadine still works okay, but in some patients, when you go up to 3 times, 4 times, it starts to make them very drowsy. Okay. Now, if you're trying to reset the system, they can't sleep, they're really struggling, you can use oral prednisolone up to maximum of 1 week. But I would strongly recommend doing a baseline blood test and urine test to cover yourself, because if you have missed an underlying infection, and by giving them oral steroids, you are aggravating their infection, you could actually make their hives a lot worse. So I think it's still safer to start with the first line oral antihistamines and go from there.
And if you use oral steroid, what is the dose like for that 1 week?
Okay, depends on the age. Okay, so if it's in a child, I would go maximum at 10 milligrams a day. If it's a child, okay, below 16. Anybody above that, probably between 15 to 20 milligrams is enough.
Oh, I see.
Okay. The elderly don't tolerate these things very well because their sugar starts to spike and all that. So it's best not to, get into a mess with all the other comorbidities when it comes to this. Yeah. But I think the first thing to look for when you have persistent urticaria, especially with polypharmacy, look at medications first. If you can identify any drugs that have been started recently in the last 3 to 6 months, then it's best to consider, pausing or stopping it first. Okay.
Okay, good.
All right, now moving on to spots. So these look quite similar to leopard spots, but it illustrates the point that you have to get a history from this. But I've chosen this photo because it does illustrate that the pigment is actually coming back on its own. Okay? Whereas with this, it's hypopigmented, meaning that there's still background pigment. But with this, is a background of depigmentation, complete loss of pigmentation, okay, with reformation of new pigment. So anyone would like to guess what this is first? Probably this.
Okay, so anyone has this diagnosis for the second picture, right? The second picture, right?
Yes,
vitiligo.
Right. Yeah, this one. Vitiligo. Very, very good.
Oh, vitiligo.
So, yes, vitiligo. Okay, how about this one here?
This one is tinea.
Yes, very good. Tinea. Tinea versicolor. Well done. Okay, so with tinea, I'll just go through the treatment pitfalls and then so that you don't lose confidence when you're treating the patients. So what I commonly see is that patients with tinea versicolor, they often have been started on the right treatment. So they've been given topical azoles, they've been given ketoconazole wash, zinc pyridine washes, and so on. But they are not patient enough to wait for the pigment to come back. So you have to understand the mechanism why that happens. So pityriasis versicolor is due to the yeast Malassezia furfur that produces azelaic acid. And in fact, azelaic acid is used as a beautifying agent with lightening pigment spots and all that in cosmetic products. So it's very effective in blocking melanocyte production. Okay. So what happens when you have yeast infection that has then stopped the pigment factory is that when you remove the inhibition of the pigment factory, you need to actually give it pigment back through stimulating with UV. So you actually get them out to go in the sun to get natural UV possible. If they want to speed it up even more, we can use narrowband UVB with the handheld device to speed up the process. Okay. Now, kid me not, I've actually had a referral from an orthopedic surgeon who refused to operate on a foot, on an ankle, because there was this. And they put in a letter very clearly saying that until this white patch looks normal, I'm not going to touch the patient.
Why?
Okay? Because they're worried that the fungal infection may infect the plates and their implants. So orthopedics are very, very particular about this. Even in the UM days, when you get referrals on them, 9 times out of 10 is this, whereby, if there's any fungal infection, you have to get rid of it quick. So normally with this, the trick here is to put them on oral itraconazole, topical azoles, ketoconazole, zinc pyridine, and UVB. And I managed to get this chap back to a normal pigment in 2.5 weeks. He was 1 month away from his surgery, and he said, if I don't get my pigment back, the surgeon's not going to operate on me. Yeah. So if you leave
why
it to
is it
nature,
always at the back?
okay,
Most
so
time.
yeah, because the Malassezia furfur likes sweaty, dark environment. So where are the common areas? Around the armpit, chest area, on the back, especially if you exercise a lot and you don't change your clothing quick enough. It's kind of sweat just sitting and the humidity traps there, and they start to proliferate.
I see.
Okay.
Okay.
Okay. Vitiligo, autoimmune condition. So treatment, phototherapy. Initially, you can use topical steroids, but then switch over to topical either Protopic or Elidel as a steroid-sparing agent. Why? Because the steroid use long-term, beyond a month, may actually cause paradoxical depigmentation. Okay? And secondly, it can also lead to skin thinning. So normally we would do phototherapy, topical steroids for the first month, and then alternating and using topical calcineurin inhibitors such as Protopic or Elidel. Okay, yeah. Other associations, autoimmune conditions like pernicious anemia, alopecia areata, thyroid hypothyroidism. So those things need to be looked out for if there are symptoms.
Okay. So this vitiligo, the discoloration we can get the pigmentation back.
Yes, we can. Especially when it's early, we can actually get full repigmentation. But if it's rapidly progressive, we actually start them on strong immunosuppressants, things like methotrexate.
But would the pigment be how you call it, even?
Good question.
Yeah.
So when we first start using phototherapy, there might be a bit of overshoot where it gets darker in some areas and it remains spotty in some areas. But with time, the color will even out.
Oh.
So it does take a while. Yeah, the timing maybe 6 to 9 months for everything to clear out. In some situations, we've also tried pigment cell transfer, where we actually take a punch biopsy of the hair root stem cell and culture the melanocytes, and then make it into a gel form and inject it back into the laser abraded area to let the pigment repopulate the sites.
Wow.
Yeah. So there are a lot of things that can be done. It's just whether we want to, invest in it, so to speak, because these things are not cheap.
Okay, we have some question. Monisha asked how long to treat tinea with griseofulvin?
I would say that probably 2 weeks is more than enough. And normally I would suggest using topicals and washes first. Because if you're using oral systemics, things can go wrong in terms of liver toxicity, systemic side effects with rashes and so on. So it's best to start with topicals first, and only if it does not respond after 3 to 4 weeks. And the way you look at response is not about the color, it's the scaling. Okay, so the scales will tell you that it is still active. Whereas if the scaling is gone and it's just pale colored and the color is coming back, just tell them to go, more in the sun, perhaps swimming or something, and the color will start to come back more evenly. During MCO, they probably have to sit in their back garden, maybe for half an hour in the morning and then half an hour in the evening, just to try to get the color back quickly.
Okay, Ying Zi asks, how do we differentiate between pityriasis alba and pityriasis versicolor?
Okay, very good. So this is coming to our next, sort of table here. So the key thing is pityriasis alba is very commonly post eczema on the cheeks, very common in young children, not due to fungus. So therefore, this potassium hydroxide examination, where you take a little scraping, you put the potassium hydroxide on a glass slide and have a look at the microscope, it will be only positive in tinea because that's the yeast infection, whereas it's negative in pityriasis alba and vitiligo. Secondly, you can look using the Woods lamp. Okay, but Woods lamp, very difficult to differentiate between the two, but it's very helpful for vitiligo because with Woods lamp, you'll start to see it glowing, it's like having those teeth in the dark in a ghost house. When you put a UV light on, you can see the white kind of area. So with vitiligo, it's very, very clear. Okay, the scales do define it quite well. So if it's very powdery, then it's more likely to be pityriasis versicolor. Okay. Now, these fine scales here is more to do with eczema and is more to do with the history. So you would ask the patient whether they've had any redness or inflammation on the cheeks before it became white, right?
Okay. So somebody asked, if vitiligo affecting peripheries and face, can it be cured as well?
Okay. So vitiligo, from my experience, the two sites which are not very curable, so to speak, are the perioral and the acral sites. So those sites are very, very, very stubborn. No matter how you beam them, you use topicals, it doesn't seem to want to come back. The ones around the eyes, surprisingly, works very well. I can get them to come back within 6 weeks or so. The phototherapy protocol is once every week and with escalating doses. All right. So it is curable for some, but for some, unfortunately, it can be quite persistent. Now, the history here is very important. So if you look at a generalized vitiligo, so about 60, 70% of their body surface area has been depigmented, then the expectation should be managed. Don't give them false hopes that, this can be treated well and so on. It's better to counsel them and to let them come to terms with it. If you have a localized vitiligo, like a young child coming in, and you have a white patch just around the eye area, and it could be nothing else, then there is reason to be optimistic because those normally respond very well, especially within the first 6 months. The longer vitiligo has been around for, let's say 5 or 10 years and beyond, the less responsive they become because the melanocytes or pigment producing cells are already completely obliterated over there. Yeah.
I see. Very interesting. Okay, we better go on because we only seen three slides.
Yes, okay, let's move on. So I would go through it so that we can cover more ground because there'll be more slides to go through. So the first thing, I think most people get very nervous when they look at these scaly things. Is it skin cancer or is it not? They look the same, they're all black in color. So this first thing here on the left is what we call seborrheic keratosis or seborrheic wart. Now, seborrhea is basically oily looking, okay, and warts is just warts, okay? But don't confuse viral wart with seborrheic warts. They're two different things. We call, or rather I call seborrheic warts very fondly wisdom spots. The older you get, the more you get, because this is part of aging. It's not sinister, but it can be quite irritating because it comes off, it traps under the towel, it itches. Common sites, face, body, can be anywhere. Okay, so this is the commonest by far, seborrheic keratosis, benign. proposed treatment to start with is probably cryotherapy, which is freezing with the liquid nitrogen, and then following up after 3 to 4 weeks to repeat it if necessary. And normally they have very good cosmetic results and it's very cost effective. Second option in line would be using a laser to ablate it, but of course for people who can afford it, right? Now, the next one here is a little bit more sinister. So if you look at it very carefully, it's got this pearl-like raised 3D, very shiny appearance, and it's on the nose, and it is stuck down. So if you to put your finger on it and try to move it, it's really stuck down. And if we put a magnifying glass on it with a dermatoscope, you can start to see blood vessels going through it. So this is the commonest kind of primary skin cancer known as primary basal cell carcinoma.
Oh, Dr. Lim got it right. Dr. Lim said it's basal cell.
Yeah, so primary basal cell carcinoma. Yeah, so well done. Now, primary basal cell carcinoma, if you look at it, this is the side of the nose here. So with sides of the nose, there are two ways of operating on this. Number one, conventional surgery, which means that the lesion is cut out and then a flap is done to repair it, which means that skin is borrowed from here. Okay, so it's cut here and then transposed onto the nose, or from here, transposed down. Okay, now the problem with doing that when you want to close the defect, because clearly this is not going to close, it's going to cause pulling up of the nose when you try and close it. So it will lead to a flaring of the nostrils. So one of the things that is commonly done is to excise the whole thing and then put a full thickness skin graft, which means we take skin from the clavicle area or under the neck and paste it there. But that has a very poor cosmetic outcome because it looks like a postage stamp with a completely different color on that area after surgery. Now, why am I discussing all this? Because when we are considering surgery for the nose, we should strongly consider Mohs micrographic surgery. Mohs micrographic surgery is not well known in this part of the world because skin cancers are not the commonest thing, although it's underdiagnosed in a lot of in primary care. But in Australia and UK, it's bread and butter. In the UK, where I used to work, we'll be cutting out at least 15 to 20 of these a week as a registrar. So in a department, you'll be looking at about 100 a week easily. And we're still catching up. The waiting list is about 6 months because the skin cancer there is so common. Now, the problem with this is that if you don't use Mohs micrographic surgery, which is frozen section controlled surgery, whereby you look at the margins to make sure that it is cleared completely before you close, there is a risk of leaving some behind. And after the flap is done, then when you get the report back, you will have to go back in again. So there are some cases where they've had recurrent basal cell carcinomas year after year after year, and they're butchered year after year after year. So you have a scar there and then it grows back in, scar and it grows back in. So what do we do with Mohs micrographic surgery? I initiated this in actually. Before this, no one did it in Malaysia because they never saw the importance. And most of these cases were done by plastic surgeons who have just cut really, really big hole, or they cut a small hole and then they get a recurrence. Yeah, because in primary care, you wouldn't want to create a very big hole because you may not have the ability or the setup to be able to close that area. So most micrographic surgeries whereby we cut one layer, okay, the patient waits in the surgical room and we get our pathologist to do frozen section on the margins. And if there's inappropriate margins, we'll re-excise in the affected area. For example, if the margin is 12, 3, 6, and 9 o'clock, and 3 o'clock is positive, the pathologist tells me, okay, 3 o'clock, there's something left, so I cut a little bit more here, and so on, until everything is completely clear. Then we can do a proper flap repair, whereby skin is transposed from somewhere else, where we will stitch onto that area. Now, once we do a flap and we commit to it, we have to be 100% sure that there's no cancer left. Otherwise, when the cancer regrows, it's very hard to retrace your steps because the flap is very cosmetically pleasing in the sense that it follows the cosmetic subunits. Therefore, you may not be able to see where you've cut. And therefore, bigger surgery has to be repeated again. Okay, so just bear in mind that Mohs micrographic surgery is the best way to deal with these things in cosmetically sensitive sites like nose or around the eyes, eyelids especially. Okay. Yeah. For the other parts, like if it was on a limb, straightforward. You can just take a big chunk out, 3-4 millimeters. It will still close. That's not a problem. But areas on the head and neck, just watch out for that. Okay. Now the next part here is a squamous or keratinizing tumor. So it is either a keratoacantoma or a squamous cell carcinoma. So this has or deserves more respect than the basal cell carcinoma because it can metastasize and would require systemic treatment like chemotherapy and so on. Whereas a basal cell, it's more locally destructive. It doesn't metastasize so much. All right, but if, in any case, when you see this, it should be referred on to have a complete excision. So this is just a summary of what we discussed earlier. So you can see it in word form, Mohs micrographic surgery. So Mohs doesn't stand for, it doesn't stand for Ministry of Health. It's actually the name of a surgeon called Frederick Mohs, M-O-H-S. And he was a general surgeon in the US who first used chemicals. So it's called Mohs chemosurgery to do the first ever so-called frozen section at the time using chemicals to delineate whether there was cancer left or not. But now it's done as a rapid frozen section and then quick analysis.
Well, it must be very stressful for the patient and the pathologist to keep on having to look at the signs and then re-look again when you do the second excision.
Yes, yes, it is. So it's often quite time consuming. It's about 6 hours.
Yeah.
I wouldn't say that it's stressful for the patient because the patient actually gets quite bored. Because when we excise, we just cut one lesion.
The waiting, you know?
Yeah, the waiting, yes. They have to wait around and all that. But yes, for the pathologist, it's high stakes because frozen section is not the easiest thing to analyze. And they have to commit to it before the formalin fixed sections. Yeah. But this is one of the most satisfying kind of surgeries to do because there's a lot of finesse to it. And once you do a good job, they get a very nice cosmetic outcome and the problem doesn't come back again.
Okay, I just tell a short story. So I was I was a house officer, and this 90-over-year-old lady from a nursing home came in with maybe a 20-cent coin and maybe 1 or 2 centimeter deep hole on her cheek, very near her eyes. And of course, it's actually basal cell carcinoma. But when we look into it, the whole hole was full of maggots.
Yes.
Full of maggots. And we couldn't pour in what do you use for maggots? Kerosene or I don't know what. But we couldn't pour it in because it was so near her eyes. So my colleague then went into the OT to try to pick turpentine. Okay, Monisha said turpentine. So he tried to go in and pick every single, maggot out. And then he chickened out and he said, "Better you go in." I couldn't do it either. My legs were so jelly. So in the end, the next day we put her on an OT, emergency OT list. We don't know who did it actually. It was really, really difficult.
Yeah, actually, maggots is nature's way of debridement. She's actually having free debridement, the maggots are eating away the dead skin tissue. Yes. Otherwise, it would be a lot more mucky and it's probably getting it, she would have been
to pick out the maggots. Oh my God. Okay, that's the end of my story.
Okay, so this, I'm sure everyone knows, flexural rash, itching in a young child. Okay.
Eczema.
Eczema, yes, atopic eczema. So atopic march, allergic rhinitis, atopic eczema, and then asthma. Okay, so now the one on the right here is the one important that's not to miss. So if someone has a rash all over the body and you can't figure out, the next place you should look is the palms, because the palms will narrow your differential quite a bit. So if you look at the palms and you see this, there are a few things. If it's blisters, okay, it may be hand, foot, and mouth disease, especially if there's blisters in the throat, there's fever, hands and feet blistering, okay, in young children, especially in the history with a history of outbreak in nursery or something. Next thing, secondary syphilis. This is not secondary syphilis, but secondary syphilis, macular papular rash all over, but it will tell you the tail on the palm. So if you see a palmar rash, make sure you send a VDRL, because if you see a macular papular rash all over and you diagnose as allergy, if you give a triamcinolone shot or you give them oral prednisolone, it may progress to tertiary syphilis and neurosyphilis. So it's a very dangerous thing to do without doing the blood workup. So key thing, look at the palm. But anyway, we'll come back down to what this condition actually is. So this is a target type lesion. So did anyone get that?
Somebody say Lyme's disease. Somebody say erythema multiforme.
Yes, so erythema multiforme. So these are actually, this is a zoomed in picture of what is happening on the hand, on the palm. And this is a bullseye target type with 3 concentric circles, very typical of erythema multiforme. So erythema multiforme is on a spectrum. It can be associated with Stevens-Johnson syndrome and also can be associated with TEN, toxic epidermal necrolysis. So I'll just recall a case which I remember very distinctly when I was in UM. There was a lady in her 60s, went to an outside lab, which I can't name which one, did not see a doctor, saw a lab assistant who interpreted the blood results for her. Madam, your uric acid level is up, so let's start you on Zyloric or allopurinol.
Okay.
Even though she did not have a single episode of gout ever in her life, no joint pains whatsoever. And she took that for about 2 or 3 weeks. First of all, she had a bit of eye irritation. So she went to her GP. The GP said, oh, eye allergy, gave her some steroid drops. Got a bit better, so she just kind of ignored it, went back. And then, so this was about 3 weeks. After that, her mouth started to have ulcers. Went back to the GP again, a different GP this time. And the GP said, oh, probably herpes simplex infection. So gave her some acyclovir oral for about a week and gave her some oral 7-8 and that sort of things to just alleviate the symptoms. And then she was carrying on all this while with Zyloric, with allopurinol, no history taken. Okay. So then the rash started to spread to the body. Okay. And the patient went to accident and emergency in UM. Medical officer saw the patient and saw, oh, eyes, irritation and red injected, almost sticking together, can't open, you know, the mouth, off, all sorts of appetite. And, you know, the body, a bit of target type lesion. So, okay, this is probably HSV with erythema multiforme, right? So again, give oral antivirals, gave some topical steroids and send her home. So, you know, she's gone to 2 GPs, she's gone to A&E, and she was sent home multiple times and she thought nothing is wrong, you know? So she decided to just rough it out. She continued taking allopurinol. And by this time, it was about week 9 or week 10. And she became bedbound, fever, cannot move, cannot get out from bed. And the doctor came to visit, immediately brought her to A&E in UM. And she had the worst case of toxic epidermal necrolysis. Skin was peeling off as though she came from a burning room, as though she was coming from a burning room, you know? Skin was just flaking off like mad. Can't even recognize her. You know, the face was like triple the size, skin was peeling all over. When we did bloods, she had renal failure.
Oh
she
my
had,
God.
Yeah, she had to go on, you know, dialysis. And she was admitted to ICU because she had pneumonitis as well at the time. So in the end, she spent about 2.5 months in ICU, came out to the general ward and never got back on her feet. She never got back on her feet. And, you know, the story here is to take a drug history. And if anything that is, you know, disturbing the eyes or the mouth, always think of Stevens-Johnson's first. You will never regret that, because if you miss allopurinol or for that matter, certain anti-epileptic drugs, you know, then it is persistent. Because you see, with oral antibiotics, it's very short-lived. Normally, you take it for a week or 2 weeks, so the reaction stops there. But things like Zyloric, allopurinol, anti-epileptics, they keep taking it if you don't tell them to stop it. And this can lead to very, very severe cases. So it's just a thing to share so that everyone is aware of it. Yeah. Okay.
Okay, I got stories to tell, but go
Sure.
ahead, go ahead.
Okay. Yeah, there's a few more slides.
Yeah.
Okay, so this one here, I think is quite clear. We talked about it earlier on, HSV1 or herpes simplex virus. Now, HSV1 normally isolated from the lips, HSV2 normally isolated from the genitals, but with new sexual practices, it crosses over now. So sometimes you see HSV2 on the mouth, HSV1 in the genital area. Okay, But with all intents and purposes, you treat it as herpes simplex. So you start with oral antivirals. Now, topical Zovirax is not that effective because oral antivirals actually work on the basis of inhibiting DNA synthesis of the virus and stop replication. Okay, but if you have secondary impetigo like crusting and all that, you'll probably need topical fusidine or even oral antibiotics to stop it. Okay? Now, the kind of cousin condition here is quite easy to spot here, but this is spot the spots, right? So of course, it has to be something quite obvious for you to see. But what I can sometimes sense that there are some cases that have been missed as zoster, especially around the head and neck area. So where they get disturbance around the forehead and eyes, they're misdiagnosed as cluster headaches or some migraine episode 3 days before the blisters come up. So can't fault you because basically you don't have any blisters to go with, and all you have is a patient saying it's very painful around there. When you look at the skin, it's completely normal. So you're going to start thinking, yeah, it's probably migraine, probably cluster headache or whatever. So you send them off, and then 3 days later, they develop the blister. And then they think, oh my, the doctor missed herpes zoster. And now my eyesight might be threatened because it can cause scarring in the eyes. So every time when you can remember an invisible pain, meaning a pain that cannot be explained in a dermatomal distribution, think of zoster. Tell the patient you're thinking of zoster, cover prophylactically with acyclovir, because there's very little harm that can come from it, besides the rare side effect of crystallization in the kidneys. So all you have to tell them is just drink lots of water, cover for zoster, and you can save a lot of long-term complications. Because when they're diagnosed late, by the time they have this, they often have persistent neuropathic pain that requires pregabalin or gabapentin to control the chronic discomfort after. Okay? So take-home point is just to consider zoster when it's an invisible pain, especially in the first 3 days. The other hints you can get is when patients say that they are feeling fluid, kind of flu-like symptoms, a bit tired, maybe mild fever, some sort of prodromal symptoms, and that would be very supportive of herpes zoster coming on. Okay.
Sorry, Adrian, can I ask you? I just recently saw a patient who was diagnosed to have herpes zoster, and I think the diagnosis is very correct because of the distribution. But the blisters are still there after about 6 weeks.
Then that is very unlikely to be herpes zoster. Because because blisters basically means that the skin cells have died off and the cells have just leaked out their cytoplasm, right? So all the fluid and everything is just under the skin. So blistering conditions are a lot of differential. It can be a burn, physical trauma, burn, chemical burns. It could be bullous impetigo, which means that there's infection with staph or streptococcus, which causes that. Then, of course, you have to consider localized bullous pemphigoid. Okay, bullous pemphigoid, where there are persisting tense blisters, which are very itchy. Okay? And of course, sometimes it can be as simple as just a plaster allergy that is not diagnosed, and they keep putting the same plaster there, and it just forms a blister that's bigger and bigger each time. Okay, yeah. So 6-week history of herpes zoster unheard of, because by that time it would have popped. So I think you have to revisit the diagnosis.
Because this lady was referred to me for an echo. She has underlying cancer. I can't recall the thing, but she told me that she was diagnosed with herpes zoster, and then because the site is where I was going to put my probe on, you see. Okay. So I was like thinking, I'm so sorry, how long have you had this? She said it was diagnosed about 6 weeks ago. I said, well, how come you're still having blisters?
Yeah, very unusual.
Yeah.
Now, but in the immunocompromised, you do see very odd clinical patterns. So sometimes there's no pain at all, but you see this ulceration that comes up in the V1 periocular area, dermatomal V1, and there's no pain, nothing, but it's just ulceration. But when you give them high enough doses of acyclovir or valacyclovir, then it responds. So if it's a chemo patient, possibly it is coming and going, kind of almost becoming a chronic zoster infection, possibly, where it was treated and then it came back because her immune system is just so suppressed.
I see. Okay.
That's possible too.
Okay.
Yeah. Okay. Now, this is a very common thing I think all of us would know from afar. But the reason why I brought these pictures in is to just remind ourselves not to overuse topical steroids blindly. It's not always our fault. Sometimes it's the patient's fault because they think that they can just Google it and go to the pharmacy and ask for a medication and they get given a steroid combination. And so tinea infection can become very complicated when there's steroid in the mix because it causes local immunosuppression, which then causes the tinea to go into the deep parts of the hair follicles. When that happens, you need systemic oral antifungals for long periods. The other category of patients where I've seen long-term itraconazole required are those with the kind of animal fungus, yeah, cherions or the kind of animal dermatophyte infections from their hamsters, from their pets. Those are incredibly resistant. They just, they won't go off very easily, you know. The normal fungal infection between the toes normally takes maybe a week or 2 weeks, you start seeing clinical improvement. But some on the body and the arms from animal fungus, it can last for as long as 4 to 6 weeks and is highly infectious. So normally when one member of the family gets it, it spreads to the husband, spreads to the kids, spreads to everybody, you know, so it gets passed back and forth. So you have to treat the whole family as one, right? So tinea infection, I think it's just basics, topical azoles or topical terbinafine. If treated with topical steroids, it would lead to spreading. And especially if you abuse, so-called abuse or overuse steroids in the groin area, by the time you examine the patient, you see striae, you know at least they've been using it for at least 2 months or 3 months. Recurrent cases are often due to diabetes and immunosuppression, and of course, sweaty areas. So for overweight patients, areas under the breast, in the groin area tend to be very resistant. They keep coming back because of the local factors. So for those, you can consider using ketoconazole powder to put underneath as a prophylaxis to prevent it from coming back. And then finally, if it's a non-responsive tinea infection, it might well be erythrasma, which is actually a bacterial infection. So if something doesn't respond to antifungals, take a bacterial swab from the area and just wait for the culture. Most of these will respond to things like oral clarithromycin or topical clindamycin. Okay, just a few more to go. So scalp lesions here. Why I've put this photo up, because it was managed as an eczema in primary care. But in fact, this Caucasian gentleman has actinic keratosis, which is the precursor of squamous cell carcinoma. So it's a sun-damaged spot, and these will need cryotherapy initially. And if it continues to grow, it will need excision. Okay, so it's not eczema, it is sun-damaged area. You can see the whole area here has a field defect. So all these areas will need treatment. Alternatives to liquid nitrogen will include things like Aldara, if the patient can afford it, because it's quite pricey. And basically, you can put it 2 or 3 times a week only over the entire area to treat the superficial forms of sun damage or solar elastosis. Okay. The picture on the right here, although it looks scaly, but actually it's the complete other end of the spectrum. It is actually psoriasis. Okay, psoriasis. So psoriasis, how do you get clues as to it is psoriasis, not fungal? You look for clues on the nails. You might get some pitting. You might get some subungual hyperkeratosis. That means underneath the nail, you get lifting of the nail. Look in the scalp for thick scabs and redness, and look at the extensor surfaces, elbows, knees, and between the buttocks. Also, when you're considering psoriasis, do consider psoriatic arthropathy, because sometimes you may have arthritis coming on before psoriasis. And the key feature there with psoriatic arthritis is an inflammatory arthritis, which means it gets worse after resting. So when they sit down for long hours on a computer, when they get up, it feels painful and stiff, and it gets better after moving, as opposed to osteoarthritis, which is wear and tear, which is basically when you use the joints more, and towards the end of the day, it gets worse. So it's the opposite end. All right. Okay. Any questions?
The last picture, somebody asked whether it's SLE.
No, not SLE. So SLE has much less scaling on the surface, okay? And the distribution is normally more on the cheek area, on the malar cheek area. Demographics, young Chinese woman. Other history, joint pains, stiffness, inflammatory arthritis. So if you have a malar rash, maybe you have some hair loss, and with this kind of discoid changes with scarring, okay, the skin actually scars up, and a bit of arthritis, then make sure you do your anti-nuclear antibody and double-stranded DNA serology, and you'll be able to diagnose that.
Okay,
So it's not-
any questions? Okay. You have no more slides, right?
I have, let me just see. Yeah, last one. Okay, so the last one here, blood vessel spots and blood vessel spots. Looks the
BTK.
same, but they're not the same, okay? So I think we've flashed past the answer just now. So we can see, actually here, these are very common cherry angiomas, or the other name is Campbell de Morgan spots. So yeah, they're just basically benign blood vessels or capillary hemangiomas, not related to things like spider nevi, where you are associating with liver abnormalities, okay? So it's not spider nevi, it's cherry angioma. The ones here are vasculitis, inflammation of the blood vessels, and when you press on it, it doesn't blanch. Okay, with these ones here, it also doesn't blanch, but when you put a glass on it, you can start to see this strawberry-like appearance. It bulges out, looks like a strawberry. Okay, so two very different conditions. Now, with the vasculitis, I think the key thing that we have to consider are this whole picture. So probably too heavy for an evening like that now, but vasculitis, I think the key things are whether, number one, medications. Okay, number two, do a basic blood test, including ESR and urine and CRP, and also your urine to make sure that there's no blood in it. And then you would have to slowly work your way. If you want to treat an acute vasculitis, maybe 7 days of oral steroids may be appropriate, but make sure you do the basic bloods to look for infections. If it's recurrent, then you probably have to refer on for further diagnostics. And of course, from the cardiologist point of view, I think you have to look for bacterial endocarditis and do an echo.
I'm proud to say I recently diagnosed a vasculitis in one of my patients, which there were no underlying primary problem. And then she was treated with steroids. She got well. Okay, so
okay,
that's that. So Adrian, do you mind if you close your slides, because I need to share my my slide to give them the points. Hold on.
Okay.
Now I need to share screen. Okay. Share. Where is my? Okay. So this is okay. Basically, if you want to actually scan this, go to your app, which is the MMA event app, but you must be watching on a laptop and scanning with your handphone. You can't be watching on your handphone and try to scan it. So Adrian, you can also scan it to get 1 point.
Okay.
And then eventually you will also be given 5 points for this. So if there's any question, please. Okay, come, let me see if there's any questions. So, oh no, so far, no one has any questions. Okay, now, if there's for any reason at all you can't scan, okay, please message me with your name, your IC number, your MMC number, and also your email address. We will do it manually, and please do it by this Friday, after which we won't entertain anyone else. Anyone with any question, please? So, okay, sounds like you were so enlightening. No one has any questions to ask. Okay, so with that, I'll just give you a moment or two. Okay, somebody asked, Serena asked, how long is the treatment for
erythrasma.
erythrasma, is it? What's erythrasma, please?
Yeah, so erythrasma is actually a bacterial infection affecting the groin very commonly, sometimes the armpits as well. And oral antibiotics for 10 days would suffice normally. So I normally use a combination, oral clarithromycin and then topical clindamycin in the form of T3-mycin or Topicil. And that often clears the area. But before you embark on it, it's probably a good idea to take a swab so that you can prove that that is the case. But the first line treatment is always consider fungal first. So if topical antifungal doesn't work, then oral antifungal and then possibly swab.
How is it that they all like to combine almost a lot of the either the ointment or the cream with both antifungal and steroid?
Yes. Now, the main reason historically for this is because patients always request for something that helps with the itch quickly. Okay. And so, with topical steroid use with antifungals, it also removes the possibility of irritant eczema from the excipients. So, because most antifungal creams will either have sodium benzoate or parabens or some sort of alcohol base as a preservative, right? So when you have a mild topical steroid associated with that, that removes that possibility of irritant and improves the compliance. But the problem is you may get, a more resistant treatment because the topical steroid is actually inhibiting recovery.
Okay, now the questions are coming in and there are a lot. Do you mind taking them?
Yeah, sure, no problems. I can see that on the...
Yeah, so we start with Ashwin Yo first. Would you like to, I would like just to ask about seborrheic dermatitis. Is it curable?
Now, seborrheic dermatitis, there are two components. One, yeast overgrowth. Number two, skin barrier impairment. The two go hand in hand. And the third one is normally excessive oil production. So yeast infection, easy to cure because you can use topical azoles, ketoconazole shampoo as prevention. For the barrier, you need to use an appropriate moisturizer so that it doesn't get impaired, meaning that it doesn't break down and cause the yeast infection to come in secondarily. If it's still very persistent, normally I would use oral isotretinoin, which is a sebaceous gland overactivity controller to stop the oil secretion, and that normally controls it quite well. But because isotretinoin is teratogenic, it is normally only prescribable under a dermatology license.
Okay, Charlene asked whether our question will still be answered in YouTube. Should we have any questions? No, Charlene, sorry. The YouTube is actually basically just me sharing my recording. So none of the speakers will answer your questions. Yeah, but you can always email or contact Dr. Adrian, I'm sure, for any questions. And then Cheng Huat asked, what is the treatment for pityriasis rosea?
Okay, yeah. So I'll go through the questions one by one. So pityriasis rosea, just to give a crash course of what this is, it's basically a immune system reaction. Typical history, Harold patch, that means one big red patch anywhere on the chest to start with. 2 or 3 days later, typical in the textbook is a Christmas tree appearance where it fills up the whole back. But in reality, it tends to be more diffuse than that. It doesn't just occur on the back. And typically it requires phototherapy treatment, topical steroids, and sometimes even oral steroids. But because pityriasis rosea can mimic or be a condition that looks like syphilis, normally just do a full blood count, kidney, liver, VDRL first, and just make sure there's no underlying infection. Get a history, whether the patient has been well, whether there's any family history of psoriasis, because gutted psoriasis can also look a little bit like that initially. And typically, pityriasis rosea will take around 4 to 6 weeks to treat completely. If you leave them alone, it may last for as long as 6 months or 9 months, by which time the patient gets really frustrated because they're very embarrassed by their appearance. Okay? But if the patient asks you whether it's harmful, no, it's not harmful at all. Now, the other thing that can mimic pityriasis rosea, there are a whole host of other what we call pityriasis-form rashes. Okay, so pityriasis-form rashes, there's another condition called pityriasis lichenoides chronica, which can be diagnosed on biopsy. Again, it's mainly due to an immune system reaction. Nobody knows really what really triggers it off, although some infections have been suggested. And these will require long-term immunosuppressants plus phototherapy. So normally when in primary care, I wouldn't recommend treating pityriasis rosea with topical steroids and oral steroids without getting a histological diagnosis, because then you would expose them to a lot of systemic side effects that you won't be able to defend if they were to develop life-threatening side effects, because pityriasis-form rashes are not fatal, although they are troublesome. Okay.
Sorry.
What else? Do we need to suggest sunscreen usage in patients with pityriasis versicolor? No. They should have sunlight at the right time, so probably morning sun, not midday sun. Okay, so morning sun or evening sun. Okay.
Sorry.
Yeah. Next question, Farhan. Is there something like topical antihistamines that will help with localized itching? With Piriton, calamine, topical steroid didn't help. Okay. So very good question now. Piriton can help with itching if it's histamine related, right? Calamine lotion helps by cooling, but it also desiccates the skin. So if you are trying to use calamine lotion to treat itching from eczema, then you're doing the wrong thing, because it will actually dry the eczema out and make the eczema much worse. Okay. Now, for localized itching, the key thing is to use a menthol-based product. Menthol will help to desensitize the itch receptors and make it a bit more bearable. The other little trick that you can do is, if the patient is on cheap and cheerful, you want me to turn on my camera?
No, I don't. I don't know why you disappeared.
Oh, okay. Oh, so that's fine. Okay, so you can see me now. Yeah.
Yeah.
So the other trick that you can do is, if the patients are using aqueous cream, for instance, you can ask them to put it in the fridge. And when they take it out, it's nice and cold. It reduces the itching. Yeah, because the cooling effect reduces the itch. The other little thing as well, when they are putting topicals on, tell them not to try and rub it in, because by rubbing, it either stimulates dermographism kind of reaction or histamine release, which then they will falsely say, yeah, this cream doesn't suit me because it causes more itching from the friction. Okay, so little tips like that in terms of application.
Okay. Okay, so actually, somebody asked you to show the slides that shows your email. So I will stop sharing now so that you can show the slides, the slide. And then I would ask you a question that is actually been asked by Vic Nathan from Facebook. He asked, what's the best treatment for prolonged, which is more than years, for tinea infection over the foot?
Tinea infection for 14 years.
He didn't say for more than years.
For more than years, okay. So probably recurring risk factors. Number one, local risk factors. Is there hyperhidrosis? Are there bad hygiene habits? So after showering, do they dry the area properly? That's the first question. Second thing is whether they're diabetic, whether they have any immunocompromised situations. If they do, control that well. Thirdly, prophylaxis for fungus includes candid things like, clotrimazole or ketoconazole powder. Using ketoconazole shampoo on the foot as a wash on a daily basis, leaving it on for at least 5 minutes to nuke all the fungal elements. Topical azoles can be used also when the area is dry, but if it's very, very wet and weepy, probably there's secondary bacterial infection, which means that you need some desiccating substances like potassium permanganate diluted 1 in 10,000 and rolled onto gauze, wet gauze, and put it between the toes to try and draw out the fluid from those areas. Okay.
Okay. I think we won't, we'll stop here. We've spoken for 1.5 hours, which is probably one of our longest talk. And I'm so sorry, I'm not going to admit anyone now just because they want to come in to get that CPD point. And Miss Dr. Sim Van Den, sorry that you missed the initial talk, but we always start on time. We start at 9 o'clock every Wednesday. So yes, this is a record. This has been recorded, so I will upload it on YouTube. You can watch it there. But watching on YouTube, there won't be any CPD points. And again, if you couldn't scan it, please send us your name, IC number, MMC number, and your email. And please join us at our medical forum at on Telegram. And then tell me that you can't, I'll tell you how to do it. Okay, thank you so much, Adrian. It was really, really an interesting talk. I really, really enjoyed myself, and it brought me a lot of memories throughout the years that I've seen. Okay, bye guys.
All right, good night.
See you guys next week. Next week, we will have another CPD talk, also by another doctor from Beacon. And we will actually speak about how GPs can give palliative care. Okay, bye guys. Thank you. Thanks, Adrian. Nice meeting you, even though it's in the online.
Yes, that's okay.